Hi everyone, my name's Rachel and I'm a radiation therapist at the Icon Cancer Centre in Mulgrave, and today I've been invited to share a bit about our initial experience with the Align RT system. So just some background, I'll begin with just a really brief background into surface-guided radiation therapy. I'll then go into more specifics about our experience with the system to date, including implementation, sharing some initial data and just some general learning outcomes, and then just finish by touching on some future directions and plans. So surface-guided radiation therapy, or SGRT, has emerged as a radiation-independent and non-invasive way of verifying a patient's position through utilising surface localisation and surveillance for patient setup and monitoring. In practice, it's been applied to a wide variety of treatment sites and techniques and has resulted in numerous benefits, many of which we've already heard about today. Listed here are some of the benefits that first attracted us to the system. And in particular, I'd highlight the potential to improve the workflow and accuracy of treatment, and also the opportunity to provide tattoo-less treatment to our patient, which is essentially our end goals. So Align RT is Vision RT's surface imaging solution. At Mulgrave, we've got a 3-camera pod system, which we use in conjunction to our TrueBeam, as pictured here. So without repeating too much about what has already been said today, the pods project a speckled pattern onto the patient's surface, which in turn provides the texture variations needed to create a 3D reconstruction of the patient. So this reconstructed surface can then be matched in real time to a reference image, and that aids in positioning. So region of interest, shown here in white, defines the area, the surface area that will be used by the system during registration. So this is set by the user, and it can affect the accuracy of treatment, as you've already heard a bit about today. So this is a depiction of our version of the system. I believe it's version 5. So when it's switched on, it provides live feedback of a patient's offset from isocenter. We can see on the left of the screen this in the translational and rotational axes, and on the right of the screen a 3D visualisation of this process. So when the patient is in the right position, the surfaces will overlay and everything will approach 0, and this indicates that you're all good to go, and we would then proceed to imaging. So as I alluded to before, the Align RT system is still quite new to us at Mulgrave. We're the first department in the wider Icon group to use it. While it was installed back in February last year, there has been a bit of lag time between instalment and training and proper use of the system. So I should also mention that our department is quite new. We just turned 1 last month, and we celebrated the anniversary of treating our first patient just a week or so ago. So along with trying to integrate a new system into our processes, at the time we're still actually trying to establish core processes, which I guess sort of increased the complexity of the situation. But regardless, this is a general workflow of what we're sort of following for implementation. So I won't talk much about installation, acceptance and training, but I'm going to just focus on the last 3 steps, which we're still cycling through as we continue to optimise our use of the system. So implementation into clinical practice has involved a 3-phase technique, which allows us to continually increase our reliance on the system as our confidence builds. So phase 1 is basically just testing the system, so to see if it can work, or I should say we are able to use it as intended. So in this phase, we just set up patients normally to their tattoos, image and treat, and just have Align RT switched on to passively track their position. As we then progress to phase 2, we still set up to tattoos, but we'll make fine adjustments according to the Align RT system. And then finally in phase 3, that involves just setting up to Align RT alone, 0 reliance on tattoos, but we do still give patients tattoos at simulation, just more as a contingency. So basically this is all leading towards being tattoo-less, which before we're able to do, we need to ensure that firstly we can trust the system, and secondly, also trust our ability to use it well. So one of the first things we thought would be necessary to assess was the accuracy of Align RT in gross patient positioning. So if we are to accept it as the new standard of care, we first need to understand how it sort of compares to our current standard, which is why we're spending quite a bit of time contrasting the setup accuracy between tattoo-based and Align RT patient positioning. And we've started off by looking at pelvic and breast treatment sites, as this makes up the majority of our patient cohort. So for some initial data analysis, what we did was we analysed the first 336 imaging sessions of patients receiving treatment to their pelvis or breast area who had Align RT passively switched on to track their position. So from this, we extracted two sorts of data. So firstly, the actual shifts to isocenter made from standard setup, and then also the suggested shifts in the Align RT system following corrections made from imaging. So this second data point was used to analyse the system's displacement from isocenter. So these graphs here show the displacement from isocenter in centimetres for tattoos in blue versus Align RT in orange for pelvis patients in each of the axes. So ideally what we would want to see is tall, narrow graphs, as this indicates that the error is almost always zero. What we can see in this case is that the two curves are quite comparable to one another. So the greatest accuracy for pelvises was seen in the lateral direction, and you can see that through the high narrow peak. As we move along to longitudinal and vertical axes, they begin to get shorter and broader, indicating that there's slightly more error. And same thing, the results for the breast here. So again, two curves overall are generally quite comparable to one another. The greatest accuracy for this set of patients, however, was in the vertical axis. So it's easier to see exactly what sort of error we were working with by looking just at Align RT's displacement alone. So this is the same data but graphed as a box plot instead. So here the blue line is the 5mm mark and the centimetre line is shown in orange. So overall, the majority of treatments were within a 5mm target agreement. However, there are some cases that were over a centimetre, and I suppose this was an endpoint that we were specifically interested in looking at because it represents our threshold for re-imaging. And again, similar for the breasts. So majority within 5mm and some again over that centimetre threshold. So from initial analysis, we found positioning through Align RT could be comparable to tattoo-based techniques for pelvis and breast radiation therapy treatments, with the greatest accuracy being seen in the lateral axis for pelvis and the vertical axis for breast. Variation, however, does exist, and it's important for us now to understand the reasoning behind this so we can continue to improve our use of the system. So listed here are some well-documented reasons of variation of the skin surface to target correlation. Basically, on the right of the screen, you can see the effect that inconsistent bowel and bladder prep can have on a patient's contour, which is particularly important to consider in this patient cohort. So similarly, you could imagine what some of these other listed reasons, the effect that some of these other listed reasons could have. So anecdotally, this was also reflected in some of our initial data. So this graph here compares Align RT's displacement from isocenter for two different study patients. So patient C, shown in yellow, had much more difficulty achieving the desired bladder and bowel preparation compared to patient G, who was far more consistent, and this is reflected in the shape of their distributions. So similarly here, we can see that effect for breasts. So patient B had much greater displacement, and she also has more pendulous breasts compared to patient H, who was more stable. So essentially, with this in mind, we need to then think, what can we do to address some of these issues? So one of the main learnings that came out of our initial data was the importance of regions of interest. So as previously mentioned, the ROI defines the surface area that will be used by the system during registration. So since we're relying solely on imaging the skin surface, this needs to be as representative of the target surface as possible. So it seems quite intuitive, but little changes to everyday practice may be needed to achieve this. For example, in pelvic patients, we've had to reconsider the placement of sheets or undergarments to make sure they're not being included in the ROI. For breast patients, we're still defining exactly how best to set these, but considering things like, for example, should we actually exclude the breast region? Although it's a target area, it can be quite mobile and therefore unreliable. So there are lots of different factors that sort of go into it, and they can vary on a patient basis. But the good thing is that we are able to draw on the experience and expertise of many other users, which has really helped us along in our ability to customise our ROIs. So it's a learning process, but we've already seen some improvements in our use of the system. So the box plots on the right represent a further 105 and 168 sessions that were analysed following the initial data on the left. So you can see that there already is some improvements made. The range is much smaller and mostly within that 1 centimetre mark, which really early days is what we're aiming for. So the feedback has also been pretty good. We haven't really had anything negative. So from staff, mainly I mean radiation therapists and physicists, there was some apprehension at the start, just mainly because it is a change and it does take some time to adjust and accept a new way of doing things, but there's definitely been a shift in culture, whereas at the start it was very much just an instruction from management that we had to use the system. Now we can see that everyone's really embracing it and looking to contribute to make our use of it better. Patients, we've only really had positive feedback. The most common comment we get is that the red light's really bright. But yeah, they like it too. You'll find that a lot of them are quite curious about it, interested to know what it does, and they like the idea of being tracked closely throughout their treatment. They also wish they could go tattooless. But the most overwhelming response, I would say, has been from our doctors and nurses. So they are all excited for tattooless treatment and are excited to make it the new norm. So this has been really good because even though they're not directly using the system, they're a big part of the implementation process and its success as well. So so we're still in the process, but even with our limited experience, we've already seen a lot of benefits come into fruition. So we know that it can set up patients accurately. It's also reduced our overall setup time, and we do expect this to decrease further. We've seen that the gating of treatment works, so it's able to cut off the beam when necessary, and we're still collecting data, but essentially we'll use this to inform setting the appropriate tolerances for each site. Our workflow and accuracy is continually improving, and we actually treated our first tattooless patient on Monday this week, which was really exciting, and there was no issues at all. So next, we're looking to go tattooless for more sites. So that first patient was a breast patient. Next, we'll probably go to pelvises and then work our way to just general chest, abdomen, basically anything from the head down. I think it'll be a little while before we do brains and head and necks because we haven't trialled the open mask system just yet. We're also looking to introduce more techniques, so specifically DIBH, which we currently use the RGSC system for, and also maybe some stereo treatments, which we're relying on ExactTrack for at the moment. But the overall goal is just to continually refine our use of the system and then see further improvements in our speed, workflow, our ability to reduce tolerances for accuracy. Generally we're big fans of the system and we're looking forward to implementing it as our new norm. So in summary, Align RT is an accurate, efficient and user-friendly method of treatment. Initial data shows increased accuracy with an improved and tailored approach, and optimal use of the system develops with time and familiarity. Just acknowledge some of my colleagues, and that's it. Thanks for listening.